Hello everyone, my name's Gerche. I'm a cardiologist at St Vincent's Hospital in Melbourne and head of sports cardiology at the Baker Institute. I'd like to thank the organisers of the event for the opportunity to speak to you today about the role of exercise imaging in sports cardiology. I'm going to be mixing a little bit of research and clinical medicine to really show how one informs the other. But really around the structure of bringing home three key points. One, addressing the misnomer that some of our patients, some of our athletes are too fit to have heart problems. The second, that often in athletes, particularly endurance athletes, the resting function shows an enlarged heart with low function. And exercise is really a key way of teasing out whether that represents a subtle cardiomyopathy or indeed is just part of the normal healthy athlete phenotype. And lastly, imaging, which is the topic of the talk, and exercise imaging is only part of the whole diagnostic workup. I think that's self-evident, but I'll touch upon that as well, as it's an important point. So let me start with the first point, that athletes, I think, are often perceived as being too fit and too healthy to have a significant problem. And I suspect that other people in the audience have been faced with the problem of seeing an athlete with a significant issue and wondering why the diagnostic process has taken so long or why their problems have been overlooked. So to make this point, I saw a 44-year-old still elite cyclist who was training a national cycling team. He'd competed previously in the Olympics and in the Tour de France and described fairly typical symptoms, but at a very high level of exertion, where when climbing hills around Melbourne, he was developing some left shoulder pain. On one day it was particularly bad. He went to a local hospital and was reassured and sent home without any follow-up. And my suspicion in looking back is that the only reason they could have made that, when you look at his history and everything, is that instead of taking note of the history, they took note of his muscles and felt that he was too fit to possibly have a problem. So this was his resting ECG. This was his ECG at a high level of exertion on the treadmill. And as you can see with the red arrows here, there's clear and really quite dramatic ST elevation, and later in the test, even some non-sustained ventricular tachycardia. Now, this is his resting echocardiogram, pretty typical for an endurance athlete, dilated, low normal function, but without any regional abnormalities or any hint of a problem. Whereas during exercise, immediately post-exercise, the abnormality is not subtle at all. As you can very clearly see, there's mid and apical, anteroseptal and anterior wall and apical akinesis. Really a very dramatically positive stress echocardiogram to go with those dramatic ECG findings. And he was taken immediately across to the cath lab where, as you can see, he has a large wraparound left anterior descending artery with a very tight proximal LAD lesion. And he's done very well over the subsequent 2 years, having returned to high-level exercise training of himself and his national squad. So if I just step away a little bit from exercise imaging, because I think these two studies caused a stir, and so they should have, as very significant studies, both published in the same edition of Circulation 3 years ago, that looked at coronary artery disease in athletes. And perhaps more driven by the popular media, were interpreted somewhat to suggest that endurance athletes are more likely to develop coronary disease. Now, neither of these papers actually showed that. The prevalence of coronary disease or the prevalence of atherosclerosis was similar between athletes and non-athletes in both of these studies. But what was different was that if there was coronary disease, there was much more significant calcification of the lesions, such that the coronary calcium score was higher. Now, this is a little bit akin to if we were to compare people with and without statin therapy, which is also known to harden, calcify the plaques and reduce coronary events by about 20%. So what we see in athletes is that if people have coronary disease, they're more likely to have good features in the coronary plaque and have fewer coronary events. And follow up from this nice study in the or follow up data in this nice study from Texas really informs my clinical practice quite a lot. What is shown here in the blue lines is patients with a high coronary calcium score greater than 400. In the purple of moderate, 100 to 400. Lower amounts of calcium in the yellow, and then no coronary calcium in the white. And as we move across the x-axis here in each of the groups with different amounts of follow-up, is the patient fitness. And what we can see here is that in each of the groups for the amount of coronary calcium, that provides some prognostic information. Higher coronary calcium has a higher rate of events, but as you're fitter, the difference according to coronary calcium is greatly attenuated, such that if you have a high coronary calcium score of 400, your risk in someone who's very fit is less than someone who has a coronary calcium score of around 100 who is unfit. So I use this every day in my practice because more and more people are appropriately having coronary calcium scores as part of their risk stratification. And one of the key messages, because I find that athletes are sometimes referred to me for encouragement to cut back on their exercise, where in fact the data would suggest that people should be continuing to exercise, and the worst thing that they could do would be to become unfit. So I think coronary calcium score is a very useful marker in the population, including athletes, but comes with the very significant caveat that in athletes, any given coronary calcium might have a slightly, not just slightly, a significantly lower event rate. Now, coming back to the too fit to have heart problems, this doesn't just apply to coronary disease, of course, and just as much so for heart function. And this case really sort of bowled me over. A 68-year-old Ironman athlete who had been doing Ironman triathlons for decades, highly decorated in his age group, and then had presented over many months with increasing dyspnea, initially feeling very short of breath when running into the swim, had seen a number of cardiologists, and on each occasion were more impressed by the amount of activity he was doing rather than the change in his symptoms. And finally, he presented with really almost a class 4 heart failure. And he performed a VO2 max test, which shows just what an incredible level of function he had. As you can see, a normal profile here in blue of oxygen uptake and a plateau at peak, and a VO2 max of 39 mil per minute per kilogram in a 68-year-old, which was about 2.5 times or 240% of what would be expected for your typical 68-year-old. And so all of that would suggest that this person's one of the fittest people on the planet and couldn't possibly have a heart problem. He was too fit to have heart problems. And yet, if I show you his echocardiogram, and indeed if you had assessed him clinically with gross peripheral edema and shortness of breath, you would be absolutely stunned to know just what his physical capacity was. And really all that you can conclude from this is that athletes develop a spectacular ability to use the oxygen that is delivered. And I've no doubt that this person had a reduced cardiac output, which subsequently improved with good heart failure therapy, but that he could compensate by having very good skeletal muscle. So not only can athletes, not only do we need to completely override this concept that people might be too fit, but in fact, we need to recognize that athletes can use their fitness as a way to mask very significant heart disease underneath. And as a final example, this is a middle-aged athlete who came over from New Zealand to see me a few weeks after having a cardiac arrest and a defibrillator implanted. She had been having a number of episodes of pre-syncope and a reduction in her performance as a competitive 10 kilometre and half marathon racer, still at a national level. And her syncope, I believe, had been somewhat overlooked, as had ECG abnormalities with T-wave inversion in V1 through V4, as had some mild but significant changes on echocardiogram. All had really been overlooked. And I believe it's because she was so fit that someone must have believed that fitness at that level and significant cardiac problems were mutually exclusive. So as I said, I saw her 2 weeks after having a defibrillator implanted. And so you can see the lead in her right ventricle, but presumably her cardiac changes were similar to what had been seen by the cardiologist just a short while before her arrest. And this shows clearly, to my mind, a dilated and mildly dysfunctional right ventricle, and also, in fact, a mildly dilated left ventricle. But pertinent to the topic of this lecture, exercise imaging, I firmly believe, is a much better way of bringing out abnormalities. And here's her exercise echocardiogram, focusing on the left ventricle in the image here, and showing quite a clear, again, segmental wall motion abnormality with apical lateral wall changes and a right ventricle that dilated relative to rest and had significant dysfunction. These findings required further evaluation for the possibility of sarcoid, and then, in fact, the final resting diagnosis, which we believe is a variant of arrhythmogenic right ventricular cardiomyopathy. But I find it quite impressive the degree to which the exercise imaging is required to fully bring out the abnormalities that perhaps had been appreciated may have resulted in her not having a cardiac arrest, although thankfully she did very well. Now that segues very nicely into my second point, which is that, as I just pointed out, exercise, I believe, is an absolutely key part of the diagnostic process in athletes. In athletes, the endurance athlete, the fitter they are, the more likely they are to have a dilated heart. In fact, the relationship between fitness as measured by VO2 and cardiac size, whether that be left ventricular mass, whole cardiac mass, left ventricular volumes, or indeed right ventricular volumes, that they all tell much the same thing, and there's quite a strong linear relationship between fitness and cardiac size, as demonstrated here by two of the participants in this trial, with one having a heart half the size of the other and a fitness half the size of the other. And the result of this is that if we then limit ourselves to looking at the very fittest athletes, we're seeing a subset of athletes with very large hearts and with a tendency to low normal function when assessed at rest. So this is quite a famous study by Evergel in France, who looked at Tour de France cyclists. And as you can see, a quarter to a third of the athletes had dilated hearts greater than 65 millimeters and up to nearly 75 millimeters in diameter, and a significant proportion with ejection fractions under 52%. And so this brings about the question, are these athletes, is this just part of the athlete spectrum? Are we looking at early signs of dilated cardiomyopathy? And how do we differentiate between the two? The concept of exercise imaging to assess myocardial contractility and contractile reserve has been around for many decades. Some of the pioneers of cardiology, like Eugene Brunwald, used ventricular angiography at rest and during exercise to address this question. What I would say is that the concept is just as relevant now as it was 60 years ago, but what has improved is our tools, both with echocardiography and with things like cardiac MRI, now provide us with the ability to really look at the difference. And whereas the changes may be subtle at best, they might be brought out by exercise. So this is the way in which we've been doing things for a decade now, developing this technique of doing exercise MRI, where people are brought into the scanner using a supine ergometer to exercise really up to or very close to maximal exertion. And these are some images that you can see during exercise with the diaphragm going up and down, in fact, recorded at someone doing 180 beats per minute. And from that, we can use some tailor-made software to very carefully measure the volumes of the left and right ventricle simultaneously and throughout the respiratory cycle, and in some cases combining this with invasive measures in the research setting. So there's been really quite limited data, despite the nice concept of separating out patients with varying degrees of contractile reserve. And in patients with dilated cardiomyopathy, for example, the ability to augment cardiac function seemed to be associated with a better prognosis. The question that we had was whether we could separate athletes with low left ventricular ejection fraction at rest from those people with a dilated cardiomyopathy. So we selected athletes with an ejection fraction of 52% or less and looked at their function at rest and then during exercise with the exercise MRI that I just showed. And the mean ejection fraction increased by 14%. Perhaps what's more impressive is just how homogeneous the response was, with perhaps one subject having a slightly more blunted response, but otherwise, really quite consistent results. Whereas when we looked at the population with dilated cardiomyopathy, a bit like the prognostic separation I showed 2 slides earlier, you could see there was quite some variance, and it's quite intriguing to speculate that those people with a flat or worsening function during exercise are probably those patients with dilated cardiomyopathy who might do worse, whereas there were also some that had a normal or near normal response, but overall separated out things quite nicely with a significantly attenuated response in left ventricular ejection fraction. Now, tying 2 of the earlier concepts together, there was also an intriguing subset of just 5 patients in our group who had left ventricular fibrosis and arrhythmias. What was interesting about that group is that they tended to be the more elite and professional athletes, and in fact had a higher level of fitness on VO2 max than our normal endurance athlete group. So in other words, if we'd just done a VO2 max, we would have said these were the healthiest and best athletes, where in fact they had fibrosis and arrhythmias, and their response was attenuated and much more like that of the dilated cardiomyopathies than the healthy athletes. So it seemed that this technique of exercise imaging not only was able to discriminate between healthy athletes and patients with dilated cardiomyopathy, but it could also separate out those athletes with pathology from healthy athletes when you're faced with people with a low ejection fraction. Now, the other concept that actually started our whole process and our interest in getting exercise MRI to work was the observation initially by Hein Heidbuchel, who I was working with, that athletes with ventricular arrhythmias tended to have mild right ventricular dysfunction, dilation, and also the arrhythmias almost universally came from the right ventricle, suggesting that somehow athletic training led to predominant right ventricular remodeling, at least in those people who were predisposed to arrhythmias, and led to this concept and this term of exercise-induced arrhythmogenic right ventricular cardiomyopathy, somewhat validated more recently by a group in Baltimore, a few Calkins who have called the same condition, or seemingly the same condition, gene-elusive ARVC. But certainly this condition seems to evolve, thankfully in a minority of athletes, where the remodeling results in quite profound right ventricular changes often with some scarring and attendance and the possibility of life-threatening arrhythmias. Now, this is a very difficult entity. I think it's one of the most difficult things I've been faced with in clinical cardiology, is separating out the healthy athlete with remodeling from the athlete with potentially life-threatening right ventricular arrhythmias. And part of the reason that this is difficult is because the right ventricle is often dilated in healthy athletes, and often the function is low in healthy athletes. This is some data from Arco now more than a decade ago, where he looked at athletes, healthy controls, athletes, and then elite athletes. And as you can see, this shift in normative values of right ventricular fractional area change from normal to low normal to frankly, abnormal with a median value around 35. Highlighting the fact that the more training, the more the overlap with what would seem to be pathology. So we came up with the hypothesis that those people with an abnormal right ventricle would remain abnormal during exercise, whereas those with a healthy right ventricle would augment normally during exercise, just as I showed for the left ventricle. And although it's not so frequently done in clinical medicine, I remain a little bit intrigued as to why it's not done more often, because you can look at the right ventricle very well with echocardiography during exercise. You can look at fractional area change. You can estimate pulmonary artery pressures to look at the right ventricular load. And if you have the time and the effort, you can use 2D, or in this case, colour TDI strain and strain rate to really get a good appraisal of the right ventricle during exercise as compared with rest. So looking at Arco-Tesca's experience with the low function, and here before I showed right ventricular fractional area change, here looking at right ventricular strain, and particularly in the basal segments, the athletes had higher values, which means more abnormal values than did the controls at the base and in the mid values. When we looked at that during exercise and compared athletes and non-athletes, we saw a very similar and normal augmentation in right ventricular strain and strain rate in athletes. In other words, showing that although the values might be abnormally low at rest, with a little bit of exercise, the right ventricle springs back to life in a very normal way. Now, that provided us with the opportunity to separate out athletes, normal athletes, from athletes with ventricular arrhythmias. So here we compared non-athletes, the blue lines, and draw your attention to the right ventricular ejection fraction, because this was athletes with arrhythmias coming from the right ventricle and the suspicion that they might have a subtle right ventricular cardiomyopathy. And in the non-athletes, we saw good augmentation of the right ventricular function. In endurance athletes who were healthy, we saw normal augmentation of right ventricular function. But in the athletes who had arrhythmias and who we suspected might have a cardiomyopathy, you can see a very blunted contractile response. Note also that if we used resting values, there was no difference between any of these groups, and it wouldn't have made us any the wiser, whereas exercise clearly brought out the abnormalities in the right ventricle, whereas the response was similar in all groups in the left ventricle. So to give you an example of exactly what we found, this compares a healthy athlete here to your left and an athlete with right ventricular arrhythmias on this side of the screen. And as you can see at rest, both the right ventricle and the left ventricle in the healthy and in the athlete looked normal, and indeed the measured ejection fractions were very similar. Whereas during exercise, you can see in the healthy athlete, good augmentation, good squeezing down of both the left ventricle and also of the right ventricle. Whereas in the athlete with ventricular arrhythmias, you see flattening of the septum, dilation and dysfunction of the right ventricle. Clearly abnormal and no improvement in right ventricular ejection fraction at all. So a very clear demonstration of how exercise can bring out a subtle abnormality in ventricular function that is not present at rest. Now, as I showed in one of the earlier examples, echocardiography can do this very nicely as well. And using exactly the same sort of concept, you see in the healthy athlete good augmentation of right ventricular function, but in the athlete with arrhythmias, in this case, as you can see with the defibrillator lead, the right ventricle does not augment at all. Now, to take this another step, and this might be perhaps more in the realm of research, but again, I would encourage people to pull this into the clinical domain because it can be done really quite easily if you focus in on the right ventricle with good frame rate imaging or at least high temporal resolution imaging these days. And you can perform global longitudinal strain either on 6 segments or here just on the free wall of the right ventricle. What you can see is nice contraction of all 3 segments in the healthy athlete, reasonably homogeneous timing, or at least the contraction occurring at a similar time point. And then with exercise, you see an improvement, greater or more negative values showing greater contraction of the right ventricle. And again, all of the timing are quite normal. Here in the athlete with ventricular arrhythmias, we see a normal strain pattern and strain value at rest, but with exercise, no improvement in the strain, but perhaps far more sort of significant, especially just to the subjective or the eyeball test, is that the contraction becomes grossly delayed. The right ventricle taking a lot more time to generate the force and generate the stroke volume that's required. So again, by every technique, MRI, echo using areas or echo using strain, we can pick up subtle abnormalities that just cannot be detected at rest alone. And this basically demonstrates exactly the same in line graphs with the abnormal athletes here in blue, showing a very little augmentation versus the normal augmentation in the other groups, both for strain rate, for strain, and for fractional area change. The only thing in our hands that doesn't work so well is TAPSE, or tricuspid annular plane systolic excursion. And to my final point, which is that imaging is really can only constitute part of the diagnostic workup, and here I've put a great deal of emphasis on the imaging. The problem with imaging is that whilst I can present some of the more clear examples, everything represents a spectrum, and our understanding of what is abnormal is really only as good as understanding the limits of what is normal. And this is a process that I continue to learn every day. I think many people are surprised at what we think is the extremes, as Abigail demonstrated in the Tour de France cyclist. What are the extremes of normal within a healthy athlete population? And in some of the more profound examples or some of the outliers, it can be very difficult to work out what is abnormal. And what I would encourage people not to do is to use advanced imaging techniques in patients in whom there's not good clinical suspicion. So, for example, I suspect that other people in the audience, and certainly I have been referred many athletes, could this person have a cardiomyopathy? Could this person have right ventricular cardiomyopathy? When the reason for them to have any sort of evaluation in the beginning was either screening or the asymptomatic athlete. And I'm always loath to consider, for example, arrhythmogenic right ventricular cardiomyopathy in a person who doesn't have any evidence of arrhythmias. As you probably know, arrhythmogenic right ventricular cardiomyopathy is also called ARVD, AC, but every one of those terms has A in it, which stands for arrhythmias, and I think it's a key part. So when we're looking at the athlete and incorporating imaging, incorporating exercise imaging, we need to know all about the athlete, the type of sport they do, the type of training they do. Does the degree of cardiac dilation tie into their level of fitness? What other factors may be involved? The use of medications, particularly anabolic steroids, can be a huge confounder in terms of affecting both wall thickness, but also lower systolic function. Any family history is critical, and other simple things like patient size, etc., all have a huge influence. And then all of the other tests that we do. Exercise imaging is no silver bullet. We need to combine it with ECG findings critically, with resting imaging, with advanced MRI techniques in many cases, like looking for evidence of scar using delayed enhancement. All of these things create the package in which we arrive at our diagnosis. So to conclude from everything, my key points again is that in the context of some very difficult clinical questions, is this the healthiest person on the planet, or does this person have a problem? The first thing is, don't just use fitness as your discriminator. Please don't assume that someone's too fit to have a problem. I have found that to be wrong on too many occasions, and in some cases with potentially disastrous effects. I really believe quite strongly that exercise imaging can be a very useful, if not the most useful tool in the diagnostic box, but remembering that no single test is the silver bullet that provides all of the answers. So thank you very much, and enjoy the other fantastic presentations to come.